This is an instructional video on fiber optic endoscopic evaluation of swallowing. Step 1. Preparing the patient. The first thing you want to do is determine which nares has the clearest passage. You also want to ask the patient to resist moving backwards. You also want to prepare the patient for what to expect in the examination.
The other thing I want you to do is to just try to figure out right now which nostril you think is the most clear by going like this.
Definitely my right one.
Your right one, good. That's what I like to do. Okay, so what I want you to not do is try to avoid going like this. Okay, some people want to do that.
Okay.
Okay, so just try to be real still and relaxed. It's actually not that bad. It can be a little bit uncomfortable going in, but once I get in there, it'll just feel weird, but not. It shouldn't be painful. Okay.
Step 2. Pass the endoscope through the nose to the velopharyngeal port. It is best to follow the lowest path possible in the nose, that is between the floor of the nose and the inferior turbinate, also known as the concha. Try to avoid the septum, as this is the only tender portion of the nose. There are 3 turbinates in the nose, a superior, middle, and inferior. Here you can see the endoscope passing through the right nostril. The septum is on the right side of the screen, the inferior turbinate on the left, and the floor of the nose at the bottom of the screen. As is typical for most patients, this is the clearest pathway through the nose. You know you're at the end of the nose when you reach the velopharyngeal port. At this point, you want to assess velopharyngeal competence. The best way to do this is to ask the patient to produce non-nasal sounds such as pa or s. Significant velopharyngeal incompetence will be obvious. A mild closure problem will be evidenced by air bubbles escaping through the port. Step 3. Pass the endoscope into the pharynx. It is a good idea to direct the patient to breathe through their nose or hum in order to keep the velopharyngeal port open as you pass through.
Breathe through your nose. That's a great picture.
Once you are in the pharynx, you want to ask the patient to produce a high-pitched E to assess pharyngeal wall movement. The walls should move medially in a symmetrical fashion. The amount of movement will vary from patient to patient, but if you see asymmetrical movement, this indicates a unilateral weakness in the pharyngeal constrictors. Step 5. Visually inspect the larynx for any abnormal variations in anatomy. If you observe pooled secretions anywhere in the pharynx or the larynx, this is an indication of reduced secretion management. This is an image of a normal larynx. Step 6. Assess laryngeal function. Ask the patient to say E to assess glottic closure. This clip shows a normal glottic closure pattern. Assess adduction and abduction of the vocal cords by directing the patient to sniff followed by E or to say he. Look for symmetry and fullness of movement. This clip shows the vocal cords opening and closing symmetrically and completely. Assess cricothyroid function by asking the patient to glide from high to low and low to high.
I want you to go from a low note to a high note, and when you get up high, hold it there. So go. Hopefully better than I did. Perfect. Wow. So now do high to low and hold the low.
Once you have assessed laryngeal anatomy and physiology, you are ready to proceed to food trials. What food is given and in what order depends on multiple patient-related factors. For the sake of instruction, this video will proceed from thin liquids to solids. Remember that all food needs to be a color that can easily be seen and discriminated from laryngeal anatomy. Liquids and food are typically dyed green or blue unless they are already a visible color. A white liquid such as milk can be a very good option. However, keep in mind that milk is not as thin as water, so if you choose to use milk, it is a good idea to use skim milk and to add a bit of water to thin it out even more. The first food trial you will give is thin liquid. It's a good idea on the first swallow to ask the patient to take a small amount in their mouth and hold it until you instruct them to swallow. The purpose of this is to ensure that you have a good view of the entire pharynx before they swallow. You will see whiteout during the actual swallow due to the swallowing muscles closing in around the endoscope lens. Let's watch a normal swallow in real time and then again in slow motion. Notice the whiteout during the swallow. After the patient swallows, you want to look around the larynx for any residue, penetration, or aspiration. In the next example, you will see premature dumping into the piriform sinuses prior to the swallow. It is often hard to see in real time, so let's watch again in slow motion. In your second trial, you'll typically want to do a pureed consistency. Applesauce or pudding are good choices, and on some occasions you'll want to do both. In this first example, you see a patient swallowing a bolus of applesauce. You will see that the patient has significant pooling in the vallecular space and mild pooling on the posterior pharyngeal wall following the primary swallow. The patient spontaneously takes 6 subsequent swallows in an attempt to clear the residue. Anytime you see an abnormality, you want to be thinking about potential compensatory strategies that you could try during the exam. With this particular patient, we decided to try an effortful swallow, which is what you'll see with the next bolus. As you can see, when this patient used an effortful swallow, he had significantly less residual pooling, indicating that it was an effective strategy. Your third trial will typically be a soft chewable item. This might be a cracker or cookie or something similar. This particular patient brought in a soft chicken sandwich, which is what you'll see in this next example. You will notice that he clears the first swallow relatively well, other than a small amount of residual pooling on the posterior pharyngeal wall on the left. However, on his second swallow, you'll notice he has significantly more pooling in the vallecular space and requires multiple swallows to clear. Additional trials in the exam will depend on your particular patient. They may include thickened liquids, hard solids, and even pills. If a patient reports a difficulty taking a particular pill, you can have them bring it in and actually watch them swallow it during the exam, assuming it is appropriate given their medication schedule. If you still want to assess pills and they don't have an actual pill to swallow, you can use something like an M&M or a Skittle and just instruct the patient to not chew it, but to swallow it as if it were a pill. One complication that can happen during the exam is that the lens of the endoscope can become foggy or coated with secretions or food. There are a few things you can do to try to help clear the lens. You can have the patient cough or swallow hard, or if the patient is safe on thin liquids, you can have them take a drink of water. You can also try to tap the pharyngeal wall with the lens of the endoscope, and sometimes that will clear the lens. Here's an example of a swallow clearing a foggy lens.